Hi, I'm from the Center for Gender and Sexual Health Equity in Vancouver, Canada, and I am presenting a paper on the barriers to managing chronic pain among women living with HIV on behalf of an amazing team of co-authors, including clinicians, people with lived experience, and a diverse team of researchers. First of all, I want to acknowledge that the work occurred on the unceded traditional territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh First Nation. Despite the high levels of pain among women living with HIV, there's limited empirical data that examines the sociostructural factors that shape access to pain management and experiences navigating pain among women living with HIV, which is what this paper explores. This study is part of SHANA, a longitudinal community-based cohort study with women living with HIV in Vancouver. We conducted 68 qualitative interviews between 2015 and 2017 and drew on a structural determinants of health framework to analyze the data. Within the qualitative interviews, participants outlined three main sociostructural barriers to pain management. Primarily, structural and regulatory barriers contributed to physicians' over-reliance on methadone in lieu of other opioids and non-pharmacological options, despite various negative side effects. This was largely due to prescribing guidelines in British Columbia, when adequate pain management, including non-pharmacological options, was not easily accessible. Participants often self-medicated with illicit substances. Secondly, participants highlighted how physician-patient power dynamics largely impacted their ability to negotiate pain management. In the context of large provider caseloads, participants reported experiencing discrimination, feeling that they were given inadequate time for consultation and were not adequately provided a choice of pain management options. When participants discussed being satisfied with their pain care, it was largely due to them being able to negotiate treatment options with their care providers. Lastly, discrimination and stigma largely impacted women living with HIV's access to pain management, with participants feeling that prescribing guidelines and interactions with physicians were biased against people living with HIV, people who use drugs, and Indigenous people. This led to participants feeling that they were denied certain pain care, which limited their control over their own treatment. In conclusion, participants' narratives demonstrate that there were high levels of chronic pain among women living with HIV in Vancouver, with access to adequate pain management largely being impacted by various sociostructural barriers. These findings suggest the need for an increased focus on patient-centered pain management that is responsive to diverse lived experiences with pain and substance use. We recommend a critical review of opioid prescribing guidelines across British Columbia, further physician training regarding pain among women living with HIV, and increase access to trauma-informed integrated pain management options. We want to thank all those who contributed their time and expertise to this project, especially participants, peer research associates, Shauna Community Advisory Board members, partner agencies, and the current Shauna team.